Welcome to this installment of our Friday Chalk Talk. I am Tim Earhart, the chaplain at Aurora St. Luke's South Shore Medical Center. With us today is a fellow chaplain, Jake Werkheiser, chaplain at Zilber Hospice. So Jake is working toward being a clinical pastoral education supervisor, and he will be a dang good one. Jake is also an ordained Lutheran minister. And well, most important for me, he's my friend. So, and Jake's gonna handle a very pertinent and practical topic with us today, and that is concerning the group process, because we all are in groups. We're in committees, we're in teams, we lead and participate in family meetings, we do a range of group work. So this is a skill that can be constantly developed. And so if you have questions, feel free to put them in the chat. We'll try to have some time for that, for question and answer as well. So Jake, my friend, go right ahead.
All right, thank you, Tim. So the main catalyst for this is I get to work a lot with groups, both as an educator, but also as a chaplain in general. And it'd be good to give everyone kind of a brief history of kind of what informs my group process. So I'll share a little bit of the history. So I had the benefit of being a chaplain resident at South Shore, where Tim is now. And one of the great things about that learning was I got to use my theory alongside my practice working with spiritual care groups. So we'd work with spiritual groups on the behavioral health unit. And the one of my main theorists is Irvin Yalom, kind of considered to be one of the fathers of group process therapy. And so I use a lot of Yalom's theory whenever I'm in any type of group, whether it's a family group, a group of chaplains, a group of students of any kind, a group of staff, anything like that. And so a little of my own history. I did some group work at West Allis. They have an outpatient oncology infusion unit. And so all of these patients would kind of come together and I would get to work with them, and we could do some advice giving, some of the group process that I'll get into in a little bit here. And the other thing that really informed my practice was during residency, there happened to be 2 suicides. One at South Shore, one at West Allis, and getting to work with all of the staff and helping them kind of work back from some of the trauma that they had. I also had a couple of unique opportunities at St. Luke's Hospital as well, where we had some codes. And for some of the nurses, it was their very first code. And so there was trauma involved in that. And so one of my firm beliefs is in order to kind of walk back from a traumatic event, it's being able to share in a sacred space with a group of listening individuals. So I kind of developed that, and then along with psychological first aid, kind of knowing how to manage a group of folks who have some trauma experience or an experience of trauma, and being able to help them kind of work through that. And then part of our CPE training, clinical pastoral education for any chaplain is part of group process. So we have lots of opportunities to kind of test out this theory and practice this. And then one of the things I started about a year ago was at Zilber was fresh air. I noticed a lot of the staff were having just stressors, both in personal as well as professional. And it was an opportunity for staff to kind of come together and realize they're not alone in their suffering. They're not alone in their isolation. They're not alone in kind of some of the crap that they're going through with the pandemic. So I kind of developed using Yalom and then kind of rephrasing it with my own language, kind of some practices that I typically do with groups. And I don't want to take up the whole time kind of me talking here, because part of group process is actually inviting groups to kind of share. So I'll send this slide along to you, Marty, but this is kind of some of the questions that I typically do when I'm working with groups. And it's a way to sort of engage the group as a whole and invite them to take risks. So I invited a couple of the fellows that I work with. We do some group process there. I invited some folks who are in our typical fresh air monthly meetings. So if anyone here has been in groups of mine or in groups of general, if you'd be willing to share a little bit about what that has meant to you and some of your experience, that'd be helpful.
Jake, since I have to leave the call around 10 today, if I'll just jump in here, because I really wanted to have an opportunity to talk about how impactful these group sessions are. So a couple of examples, the fresh air concept, which is for the people who work at Silver, has been extraordinarily helpful, whether it's a small group or large group. And they're successful because of Jake's ability to facilitate and get people to share. So he asks great prompting questions, but then he's really comfortable with silence, something we talked about just earlier this week, that silence is okay. People are sometimes uncomfortable with it. Jake makes it comfortable and also invites participation. And while it may not qualify as a group meeting, I would say, Jake, what I see is when we do admissions together, this is the same sort of skills you bring to a family in need. And Zilber in general is one of the best examples I've ever seen of interdisciplinary work and a true team working together. And Jake and I just love doing admissions with him, because I know we get a better outcome with families as a team than we would get separately. So thank you, Jake, for all you do. It's amazing work.
You bet. And let me know how much I owe you for that.
I'll send the bill today.
Just as a disclaimer, that Nick and I are not sharing funds.
Yeah, I would just add that when we're talking about group process, that it is distinctive from a didactic approach, in which, oh, I'm the leader and I'm telling you something or giving you information or trying to communicate something with you. It's much more about the folks themselves in the group interacting with one another and doing that communication, and then so being much more of a facilitator. I often tell patients here when I do groups that that their best chance of healing isn't going to come from me or really any of the other staff, frankly. It's going to come from each other as they learn to tell their stories and listen to one another and interact. That kind of support is what does it.
Yeah. Thank you, Tim. I saw a great question, how to make or help the groups kind of feel safe enough to share. One of the things that I found very helpful is kind of setting some boundaries, some parameters, such as for fresh air, for example. I'll say, okay, we're going to be here for about an hour to 45 minutes. So kind of giving them a time frame of kind of what we're looking at. And then kind of giving them a brief idea of what we're looking for. So one of the things that I'll sometimes share with groups is I encourage you to take risks and to be vulnerable. Sometimes that is one of the best forms of healing. And so to be able to kind of set those boundaries in a way, I'll also share some of the attributes here I have with that. So for myself, I'll typically say something like developing community. So sharing something that is a deep part of ourselves can be really helpful. The unique thing about Fresh Air is we've been doing it enough that the group typically, I would assume, feels comfortable sharing those deeper truths, but kind of creating a sense of community, even if it's only for 5 to 10 minutes, creating that safe space with boundaries can be a way. And then also talking about some of these very attributes, such as saying, you know, the more that we share, the more we're going to benefit each other. So like Tim was saying, I'm not an expert in any one area, but all of us collectively, whoever we are as a group or a community, we can all have wisdom to share with each other. And the more we share, the more wisdom the group is going to get. And some of that also comes from just modeling for myself about being vulnerable. So for example, if I was to create a vulnerable opportunity here, I might share something about, so I'm slightly nervous because I'm presenting today to all of these amazing colleagues in different disciplines. And I'm just kind of a little anxious about it. And at the same time, I'm also very excited about it. So being able to kind of demonstrate that can then invite others into that process itself. Marty, you had a question?
Yeah. Sometimes in groups, physicians can be guilty of sort of dominating conversations. I can imagine that at Zilber and hospice, where teams are used to collaborating more, that may be better. But what sort of advice do you offer to those of us, maybe here in the hospital, where there's much more hierarchy, to get interdisciplinary groups to actually communicate and share what they're really thinking and not just hearing the people highest on the totem pole?
Oh, I love that question, Marty. So a couple of things. The first is one of the things we do in our practice as educators in CPE is we have the action, reflection, action model. So we maybe lead a group, we reflect on it, and then we lead another group and we reflect on that, kind of back and forth, back and forth. And one of the things that's helpful for my own growth is sometimes just writing down, okay, how did that go? So the minute you get out of a family meeting or a palliative care discussion or something, just sitting down and typing up maybe a paragraph or two about what did I notice in myself? What did I notice in the room? And it can cue us into things that, oh, I didn't even realize this was happening. But it takes our subconscious and makes it more conscious. So one of the benefits of that is then being able to what we call self-supervise in the moment with groups. So for example, if I'm leading Fresh Air and I notice that, oh, I'm talking a lot here, I might even name that and say, okay, I noticed that I've been talking a lot here. I want to kind of step back and let others have the invitation. Or it's the opportunity to say, I noticed Tim's been sitting over there for the past 20 minutes and he hasn't said a single thing. Maybe he's angry, maybe he's frustrated. And so I might simply say, Tim, I'm wondering how you're feeling right now. What's going on with you? And so kind of being able to redirect some of the conversation with that self-supervision.
Gotcha. So not unlike a family meeting where we're naming the elephants in the room and trying to get such and such family member in the corner that you see steaming, trying to make sure that you're hearing a variety of voices and not just the loudest one. I got you.
And it's okay And it's okay to name that. So if you're noticing that steaming family member in the corner, rather than ignoring them or hoping they don't steam anymore, to just name it and just say, I see you seem really upset right now. Tell me about that. To make those, and that helps make those conversations, it normalizes it. Rather than, keeping people as, oh, I shouldn't feel that way, or I shouldn't think this way. And yeah.
And on the flip side of that is when you have someone dominating the conversation as well, to be able to keep those boundaries, as I mentioned before, as like a safe place, to be able to say, hey Tim, I noticed that you have a lot to process, and I'm really grateful for what you're processing here. I want to give a few other people some time to speak. Would you mind kind of holding that thought? And if we can invite some of the other folks to kind of share what's going on. That's a great question, Marty. Particular areas that are the hardest. I think one is as Tim mentioned, I tend to be a pretty a 9 on the Enneagram, which is to say I tend to be kind of passive, and that can cause people distress if they're not feeling like someone's in charge. And so if I have someone dominating the conversation, it's a challenge for me sometimes, because of my nature, to confront. So for example, to simply say, Tim, I notice you're kind of dominating the conversation. That feels icky to me. And at the same time, I can recognize boundaries are important and that they're really helpful. So I'm sometimes able to move through that, but that would be the difficult thing. The other thing that can be very difficult is particularly like in a family meeting, when there's a lot of people and a lot of emotions competing for one another. So to kind of set an atmosphere where, okay, let's pause and make sure that we have one person talking at a time. So again, to create those boundaries to kind of regulate that can be really helpful. The other thing that can be really helpful is groups are fascinating in the sense that they can represent sort of the microcosm as well as the macrocosm. So a group itself might take on characteristics of individual members. So for example, if there's a group of really anxious people, that can manifest itself in the group itself to create all of this anxiety that makes it difficult to process. And once again, sometimes naming that elephant in the room, like we talked about earlier, can be one of the best ways to kind of put that out there. So for example, one of the ways that would manifest, like if a group was particularly anxious, anxiety has a way of kind of blocking our ears sometimes of hearing what others have to say. And so one of the strategies I take up, and again, this is in the PowerPoint, but I might say something like, so I'm feeling a lot of anxiety in the room, and I'm noticing that Tim just said something particularly meaningful. How did you hear that, Marty? And then inviting Marty to then share is a way of helping Tim and Marty to kind of hear each other and speak each other. So similarly, in a family meeting, kind of checking what is the family's understanding of what I just said as a provider or a caregiver, to say, hey, I just wanted to check in with you. What did you hear in all of that?
Yeah. I have a question for you, Jake. So this is something that has, well, happened numerous times with me, and I'm sure with you. So I'll have a doctor come up to me and say, I really need you to talk with this patient and their daughter, family, parent, whatever. because the family's just not getting it. I mean, I gave them the diagnosis, I gave them the score, and I've tried every which way to communicate what's really going on, and they're just not getting it. So how do you handle those kinds of situations?
Yeah, one of my principal understandings as a chaplain is to come alongside patients and families kind of where they're at. One of the dangers of group process is kind of comes right alongside what family systems and where we have drama triangle. And so you might have the doctor as the rescuer, the family as the victim, and now the chaplain's going to come in and fix everything for us. So it creates this triangle that can sometimes be unhelpful. So one of the things that I typically try in those scenarios is, if possible, I like to have the provider with me when we meet with the family. If not, I typically come alongside them and say, so tell me what's going on, and kind of helping them to name some of the emotions and feelings and get those feelings kind of out in the open in a way that can help them to hear a little bit more easily what might be going on. So sometimes I've experienced this a number of times where a family is coming in and they're saying something that is contrary to what I've heard all the providers sharing. And so I'll help them kind of model through that. And then using open-ended listening, kind of using that typical dialogue. Oh, tell me more about that. It is a way of sort of getting that story out there in a way that then I can go back to the provider and say, okay, here's the barrier to their learning right now. They're really anxious. So I would invite you to kind of name that anxiety when you're with them. I'm noticing they've been through this before with so-and-so and such, and that this was their experience. So one of the ways that we might be helpful is to talk about how this experience is different from that. So kind of giving the providers a better roadmap of when they go back in the room, different strategies that they can come alongside the patient and family.
Yeah, thanks. And Leanne has a question.
Yeah, I was gonna say too, Jake, the way you summarized that was really nice. And I think the only thing that I'd add is just that I think sometimes the gap is, as you mentioned, there's something going on in the patient's life, but the clinical team often is actually imposing their own values. And I think that might be the bigger thing to recognize, that obviously it's important to understand what the patient is going through as well. And I think that's a huge value. But I think clinicians miss the boat sometimes, that the team is saying, is imposing their own values on the patient and just not hearing where they're coming from. So I think that is sometimes where we fail, is that we are putting our own values, what we think the patient should be doing. It's not that they don't understand. More education isn't going to help. They do understand, they just have come to a different conclusion than we have. And so I think that is sometimes the value is in recognizing that the problem does lie with the team. And I'm putting problem in quotes there.
Yeah, thank you, Leanne. I think that's spot on. And I again, kind of going back to that reflection, that can be a great strategy for any person, whether it's a nurse, a CNA, a provider, you name any discipline, to kind of reflect and say, okay, what's going on inside me that caused me to really butt up against this family, or not be open to hearing what they had to say. I think our best selves are the people who are active learners, and willing to learn from the family, even when it's contrary to everything we've ever known. Sometimes that can be the best learning opportunity.
Thank you, Jacob.
Yeah.
Well, thank you, everyone, for inviting me and being in group with me today.
Yeah, and thank you so much, Jake.